Hi, good evening everyone. So we'll be continuing our weekly series on drugs in dermatology and we'll be continuing with usage of biologicals in psoriasis. So last week we took a small detour and we were not discussing drugs, but last week we discussed the difference between biologicals, biosimilars and biomimics, biocopies and all sorts of words that we keep on hearing around ourselves, and we need to have somewhat a clear understanding what's the difference between biological and a biosimilar, so that you may know why your drug, which is supposed to work in one set of the patient, is not working in another set of the patients. Prior to that, we were discussing TNF alpha inhibitors in psoriasis, namely etanercept, adalimumab, infliximab, okay, and certolizumab pegol. Now, these four were FDA approved TNF alpha inhibitors to be used in psoriasis as of now. Today we are going to discuss another biological, and that would be Ustekinumab. And Ustekinumab is an interleukin 12-23 inhibitor. That means that it inhibits both of the interleukins 12 and 23 by inhibiting its receptor. Okay, so that is essentially the mechanism of action of Ustekinumab. That is, it will block the interleukin 12-23 receptor, and because of that, the interleukin 12 and 23, which are essentially a good part of the pathomechanism of psoriasis, does not go ahead with their inflammatory effects. So normally in a psoriatic patient, you will have interleukin 12 and 23 as inflammatory mediators, and it will attach itself to its respective receptors, and because of that, there will be an inflammatory cascade leading to disease known as psoriasis. What Ustekinumab does is block that receptor so that interleukin 12 and 23 is not able to act. So today in this video lecture, we'll be discussing Ustekinumab, what it is, how it acts, and what are salient features of this biological, when to use it, when not to use it. Clear? So let's begin. Now, Ustekinumab is a fully human IgG1 monoclonal antibody. Remember that it is fully human. So what do we mean by fully human biological? Number one, it's not chimeric. It is made, the protein structure is made entirely from a human derivative cell or a human cell line. Now, what is a human cell line? There are certain cell lines in which you implant a genetic material which encodes for Ustekinumab, and as the cell lines divide and proliferate, it produces Ustekinumab, and then that Ustekinumab, after a lot of processes and purifications and post-translational modification, is converted into the biological Ustekinumab. Okay, and since the derivation is from human cell lines, it is a fully human IgG1 monoclonal antibody. Okay, so and if you want further clarification of what fully human antibody means, just go back last week and look at the video on biologicals again, and you'll be able to know what exactly do we mean by that. Now, what Ustekinumab does is it binds to a shared P40 subunit of interleukin 12 and 23 receptor. Now, remember that there are two different receptors. You have 12 and then you have 23 receptor, and they share a subunit which is termed as P40. And P40 is the attachment site for Ustekinumab. So, Ustekinumab is going to attach itself to the P40 subunits, and it will block both 23 and 12 interleukin, and that is how it blocks basically these two interleukins. When these interleukins are blocked, it prevents its interaction with the IL-12 receptor beta 1. Now this part, that the protein that we were talking about, is receptor beta 1, and thus it inhibits the activity of both interleukin on T cell. Remember that T cell is one of the most important mediator of psoriasis. So, if you want further clarification, go back and see the video on pathomechanism of psoriasis. In that, we have clearly explained how it starts from keratinocyte injury, goes to dendritic cells, then goes to T cells, and because of this T cell, it gets activated, and then activated T cells secrete all sorts of interleukins, which will lead to psoriatic plaques and the psoriatic inflammatory disease. A few of those interleukins are 12 and 23, and because of Ustekinumab, they get blocked, and T cell is not activated to secrete further interleukins, and that is how the pathomechanism of psoriasis is arrested. So T cell differentiation and cytokine production is halted because of Ustekinumab. Now, Ustekinumab has been FDA approved first for moderate and severe plaque psoriasis in age group of more than equal to 6 years. So 6 years and above, if your patient has psoriasis, it has been FDA approved that we can use Ustekinumab. For psoriatic arthritis, it received its approval in 2013, while for psoriasis it was 2009. It's available as pre-filled syringes or pre-filled pens, or even as IV vials in research settings. And the mode of administration is subcutaneous. So it's a subcutaneous injection. It can come as syringe in which you have to push the plunger to give the dose. It can come as pre-filled pens in which you just have to push a button and the dose gets injected automatically. Or it can come as IV vial in which you can formulate individual doses and then give it to the patient. Clear? Regarding the pharmacokinetics of ustekinumab, bioavailability is 57.2, and this is through the subcutaneous route. Now remember that whenever a drug is given through IV route, the bioavailability should be theoretically 100% because it's getting directly into the system. But these biologicals have been designed to be self-prescribed by the patient, self-administered by the patient, so they have been converted to a subcutaneous route of administration, and that is why the bioavailability of all of these biologicals are significantly reduced. So for ustekinumab, it's one of the lowest bioavailability, 57.2%. Peak concentration occurs after 8.5 days of the first dose. Half-life is around 21 to 24 days. In all the studies which were done on psoriatic patients, the half-life was about 21-24 days. However, a good value to remember is 3 weeks. So half-life is roughly about 3 weeks. The metabolism and excretion is unknown, but remember that this is an IgG1 molecule, okay? And IgG1 antibodies are made up of amino acids and proteins. And the way they degrade is breaking down of these immunoglobulins into small amino acid structures, amino acid chains, and then they are excreted by the kidneys. So as of now, the metabolism and excretion is not known, but we can just surmise like the other immunoglobulins, ustekinumab would also undergo degradation and excretion by kidneys. Anti-drug antibodies are found to be about 3.2%. Remember that it is a fully human immunoglobulin. That's why the auto-antibodies are less. So they are 3.2%, while chimeric biologicals like infliximab, rituximab, these kind of chimeric biologicals will lead to a significant anti-drug antibodies, and the efficacy will reduce over time. Let's discuss the mechanism of action in some detail. How does ustekinumab help in psoriasis? So it binds to the P40 subunit of interleukin 12 and 23 receptors and prevents the attachment of the interleukin to its receptor. Now what does interleukin 12 do? It induces the naive T cells, and because of induction of naive T cells, it converts the T cells into Th1 cell lines. And these Th1 cell lines are going to secrete various cytokines of the Th1 line, which include TNF alpha, interferon gamma, and interleukin 2. Now, TNF alpha, as we have discussed in previous video lectures, that is one of the most important mediator in psoriasis. And because of that, if interleukin 12 is inhibited, this secretion of TNF alpha is also inhibited, and thus it works in decreasing the inflammatory cascade in psoriasis. Okay? Interleukin 23, now what it does is it activates Th17 cells. Now remember that the Th17 line is as of now the most predominant cell line in psoriasis. Okay, so Th17 and Th1, these two are the predominant cell line. Th17 is the major one. Next would be in line is Th1. So both of these lines get inhibited by ustekinumab. Now what does Th17 do? Th17 cells will secrete interleukin 17 family of cytokines, which include 17A, 17F, interleukin 22, and again TNF alpha. So remember that one of the major mediators are being secreted by both of these interleukins. Interleukin 22 will further act to increase psoriasis and inflammatory pathway of psoriasis. So remember that most important cell line will be Th17. Most important interleukin line will be interleukin 17-22 cell line. And most important cytokine chemokine would be CXCR6, CXCL10 line. Remember, if you are having any kind of confusion about these aspects, it's a good idea to go back and see the video on pathomechanism of psoriasis, where we have detailed in detail, we have discussed how does psoriatic plaque form and what are the inflammatory cascades that happen. So you will be having a better understanding of how these cytokines, chemokines are playing an important role in pathomechanism of psoriasis. Clear? Interleukin 23 will lead to interleukin 22 downstream, and this correlates with disease activity, and 22 will act with 17 to lead to form the inflammation in psoriasis. So as I have said that interleukin 17 and interleukin 22 is the most important interleukin cell line in psoriasis. Clear? So 1722 cell lines is inhibited by inhibiting 1223 interleukins by ustekinumab. Clear? Now here we can see somewhat in detail. For example, this is interleukin 12 receptor. This is interleukin 12 receptor. This is interleukin 23 receptor. Okay. Now these is ustekinumab immunoglobulin, and it binds to the P40 subunit. P40 subunit is a protein structure which is shared by both of these receptors. Okay. And when ustekinumab binds to this part, the original interleukin, which is supposed to attach itself to this part, gets blocked. So it is not able to attach and carry out its effect. So that is how ustekinumab blocks. Okay. Now, just for the people who are interested in quizzes, P40 and P40 is attached to P35 for interleukin 12, and P40 is attached to P19 for interleukin 23. Okay. Now, interleukin 12 is responsible for NK cell activation, T cell activation, and subsequently Th1 cell line activation. Now, NK cell is responsible for cell-mediated death and cell-mediated injuries. T cell activation is responsible for secretion of other cytokines. Th1 will also lead to secretion of other cytokines, and downstream there will be secretion of Th1 cell line family like TNF alpha, interferon gamma, interleukin 2. Clear? Interleukin 12 is also secreted. Interleukin 12 is secreted by the myeloid lineage of dendritic cells. Okay, and thereafter, when Th1 cell line is activated by interleukin 12, it leads to formation of psoriatic plaque. Now, interleukin 23 is secreted by macrophages and also dendritic cells. Remember that dendritic cells are the resident immune cells in the epidermis, and these dendritic cells get activated by various chemicals or DAMPs or PAMPs. DAMPs is your disease-associated microbial peptides, or disease-associated, I'm forgetting the name, but I'll tell you. So what happens is when keratinocyte gets injured by any injury or let's say infection or whatever, these secrete a lot of protein molecules, lot of moieties into the circulation, and these gets recognized by dendritic cells, and under the recognition of these dendritic cells, they present these cells to present these moieties to other immune cells like NK cells, T cells, thereby activating them. And the way they activate them is to use this kind of interleukins. Okay. Now, interleukin 23, after acting through these interleukin 23 receptors, the signal also goes through JAK pathways, and that is why JAK inhibitors are now being used. It's a very commonly used in psoriasis now. So JAK STAT pathway is a pathway utilized by interleukin 23, predominantly JAK2 and tyrosine kinase 2. Now remember that there are three types of JAK1, 2, 3, and fourth is tyrosine kinase. Okay, so these are the JAK receptors, and we'll discuss them and we'll be discussing in the future Premilast. Now this JAK further activates the STAT group of proteins, and STAT group 3 and 4 are implicated for interleukin 23. Okay, now this STAT and 3-4 will further lead to translation of inflammatory molecules and increasing the inflammation in psoriasis. Okay, so let's go forward. Today we'll be discussing only interleukin 12-23 combined inhibitor, that is ustekinumab, but there are specific biologicals which block only interleukin 23. So they include guselkumab, risankizumab, or mirikizumab. These are some biologicals that I can remember on top of my head. Okay, So we'll be discussing only interleukin 23 receptors, interleukin 23 blockers in subsequent videos. Depending after interleukin 17 inhibitors, we can discuss only interleukin 23 inhibitors that we can do. Okay. So this is just a flow chart, and this is from Wolverton, the chapter on Ustekinumab. So just to remind you that this is interleukin 12. This is interleukin 23, and these are two interleukins at the center of the pathway, which will be blocked by ustekinumab. Interleukin 12 is going to activate the Th1 cell line, 23 will activate Th17 cell line, Th1 will secrete TNF alpha interferon gamma, Th17 will secrete 17 family, which is A, F, and 22. Both of them will act on keratinocyte. Okay, and keratinocyte will lead to proliferation, increasing scales, increasing thickness, increasing induration of the psoriatic plaque. Clear? The keratinocytes are going to secrete a lot of mediators, mainly the antimicrobial peptides, interleukin 6, TNF alpha again, CXCL group of proteins, and this will act on macrophage. The macrophage will secrete TNF alpha, which will act on myeloid dendritic cell, and this cycle will continue. So it starts as just the activation by the dendritic cells, which is usually by keratinocyte injury. So keratinocyte injury activates dendritic cells. Dendritic cells plasmacytoid variety will activate the myeloid variety. The myeloid variety will further activate different T cells to secrete interleukin 12, interleukin 23, and subsequently downstream cytokines. And then it becomes a cycle, and inflammation keeps on increasing. So this is just in short how psoriasis and different cytokines act. But again, I'm telling you, go back and see the video on psoriasis pathogenesis, and it will be easier for you to understand. Now, this slide I have taken from the psoriasis video. So just to recapitulate, keratinocytes are going to secrete various moieties when they are damaged. Now, beta-defensin, cathelicidin, LL37, and self-DNA are antimicrobial peptides. And this will activate plasmacytodendritic cells, which will activate through toll-like receptor 9 and will secrete interferon alpha. Cathelicidin and self-RNA will activate the myeloid variety of dendritic cell, which will secrete TNF alpha, interleukin 23, 12, and 6. Interleukin 23 is going to formulate the maturation of naive T cells to Th17 cells. That is, under the presence of interleukin 23, the naive T cells which will get converted to Th17 cell line. And then Th17 cell line is going to secrete interleukin 17, interleukin 22, TNF alpha. Okay. Furthermore, interleukin 23 is going to downregulate FOXP3. So FOXP3 is responsible, just to revise, that FOXP3 is responsible for increasing regulatory T cells. So when FOXP3 is downregulated by interleukin 23, the regulatory T cells are also downregulated, and because of that, the stoppage of activated T cells goes away. Okay, so let's just understand this basic concept. We have a T cell who is doing nothing. That T cell gets activated under the influence of various cytokines in a psoriatic patient. After activation, this T cell will secrete a lot of other cytokines, namely 17, 22, TNF alpha. This is the normal mechanism in psoriasis. These cells will get inhibited by regulatory T cells. Now, regulatory T cells are going to suppress this activated Th17 cell. For regulatory T cell to act properly, you require FOXP3 activation. FOXP3 gets suppressed by interleukin 23. So 23 will suppress FOXP3. FOXP3 will suppress T regulatory cells, and suppressed T regulatory cell will not stop activated T cell, and thus activated T cell is going to secrete a lot of cytokines. And that is how interleukin 23 is responsible for inflammatory cascade. So when you block interleukin 23, namely by using ustekinumab, the inflammatory cascade also gets blocked. I hope I'm making myself clear. If not, then see this video again, maybe at a slower speed, or go back and see the pathomechanism video of psoriasis. You'll be able to have a good concept of how different interleukins are acting. Okay. So let's get back to ustekinumab and how to give ustekinumab. So it has been divided into two phases. Number one is for adults weighing between 60 to 100 kgs. Other is adults weighing more than 100 kg and less than 60 kg patients. Okay, so let's just make things simple. So every green box is a 45 milligram dose of ustekinumab. So first we'll give a 45 milligram initial doses, then we will wait for 4 weeks, then give again 45 milligram initial, again a second dose, then we'll wait for 12 weeks, then 45 milligram 12 weeks, 45 milligram 12 weeks, 45 milligram 12 weeks till the psoriasis is under control. Okay, so first dose 45 milligram, after 4 weeks give another 45 milligram, then after every 12 weeks you give 45 milligram ustekinumab. If your patient weighs more than 100 kg, you just replace 45 milligram with 90 milligram. That means you just double the dose. Clear? Less than 100 kg, give 45 milligram, 4 weeks, 45 milligrams, and then every 12 weeks, 45 milligram. If more than 100 kgs, give 90 milligram initially, wait for 4 weeks, then give 90 milligram, then every 12 weeks you give 90 milligram. Clear? If your patient weighs less than 60 kgs, the dose is 0.75 milligram per kg, and this is also the pediatric doses. Okay, so ustekinumab has not been approved for less than 6 years of age of patients. But if you have a patient between 6 and 12 or 6 and 18, and you need to calculate per mg per kg dose, it is 0.75 mg per kg. Okay. Now let's discuss the response to psoriasis. It has been said that PASI 75, that is 75% reduction from baseline PASI, is seen in 70 to 75% of patients. And this data that I'm telling you is for 45 milligram dose. If you use the dose 90 milligram, there is not much difference. 75 will become 80 at the most. Okay, so that is why I'm just mentioning about PASI 75 when you use 45 milligram of, let me just erase everything here. So if you use 45 milligram of ustekinumab, PASI 75 is 70 to 75% of patients. PASI 90, that is 90% reduction from baseline PASI, is seen in 45% of patients, and this is seen at week 28. Okay, so what do we mean by week 28? We have week 0, then 4 weeks, then 0, then 12 weeks, then 0, then 12 weeks, and then 0. So 1, 2, 3, 4. 4 plus 12 plus 12, 28. So at the end of 4th doses, we'll see what is the amount of reduction in PASI. And in 70-75% of patients, you will have 75% reduction. In 45% of patients, you will have 90% reduction. If there is no significant change at week 28, you stop ustekinumab. Okay, so stop ustekinumab if there is no change at week 28. Okay, so remember 28 is the magic number. If there's no change, then stop. Apart from psoriasis, ustekinumab has been used in various other disorders, but these are all isolated case reports. It has not been approved for any other indication in indication in dermatology. And these are all isolated case reports, and there is only few or mild improvement with ustekinumab. Okay, so these include hidradenitis suppurativa, atopic dermatitis, Behçet's disease, in which we see only mild improvement in all the symptoms within 3 months of using ustekinumab. Pyoderma gangrenosum requires a higher dose, 90 milligram every 8 weeks. Bullous pemphigoid, PRP, SLE, LP, sarcoidosis, even vitiligo. And there is one case report that I found was mild benefit in harlequin ichthyosis. I read that case report, was not very clear how it acts in harlequin ichthyosis, but there is a it has been for the past 5 to 6 years that inflammatory mediators can be used to treat ichthyosis because of the action of various interleukins on keratinization process. And there are very good papers by Amy Paller if anybody wants to go and search and read about it. I read about it around 2-3 years back, and in which various biologicals like infliximab, secukinumab, All of these have been used successfully in treatment of various other forms of ichthyosis. So it's a good article to read if you are, not doing anything and want to just learn new things. Okay, this all uses I've taken from a review article by Rawal et al. And I'll include this URL in the description, so you can just copy paste and read the original article also. Okay. Now storage. If you're using a vial, it has to be diluted with NS, and if after dilution, you can store it for maximum 7 hours at room temperature. And when we say room temperature, we mean 25 degrees Celsius, not like India where it can go to 35. Okay. So at 25 degrees Celsius, a diluted vial can be stored for 7 hours. You have to examine for particulate matter. Now remember that Ustekinumab vial can be white to yellow, and there can be slight particulate matter in that vial because it's a protein structure. But it should not be suspicious. So not to use a vial which has particulate matter. For storage, it has to be refrigerated from 2 to 8 degrees Celsius, and this include for undiluted vial, pre-filled syringes, and pre-filled pens. Okay. You have to store it in the original carton and protect from sunlight. Do not freeze, and if it gets frozen, you cannot thaw and use it. Once frozen, you have to discard it, and do not use it after expiration date. That goes without saying. Okay. So if the pre-filled vial is of 45 milligram, it will have 0.5 ml, and if it is of 90 milligram, then it will have 1 ml. The vial comes of 130 milligram per 26 ml. That is, the concentration comes at about 5 milligram per ml. So if you're using a vial, I don't think so you'll get access to vial anytime. But if, let's say, theoretically you're using a vial, so the concentration of vial is 5 milligram per ml. So if you have to give 45 milligram, you have to take 9 milligram and inject subcutaneously. Okay. Now, remember that pre-filled syringes have to be stored in refrigerator from 2 to 8 degrees Celsius. However, if you store them in room temperature, it can be stored for up to 30 days maximum. But after 30 days, you cannot use it even if you freeze it. So remember that from the day of manufacture, if they are not refrigerated, maximum storage is for 30 days. After that, you have to discard. Baseline investigation is same as we do for other biologicals: CBC, LFT, KFT, ESR, CRP to look at psoriatic activity, urine routine microscopy to look at any infection and kidney and functioning issues, Monto test, IGRA, and chest radiograph to rule out tuberculosis. That has to be done. Viral markers, HIV, ELISA, look for any other immunosuppression comorbidities, and any sign of infection has to be thoroughly inspected so that you do not give biologicals in a patient who is suffering from or have a foci of infection. So that has to be treated first, and when it is significantly under control, you may consider giving the biologic. To administer Ustekinumab, it has to be administered within 8 hours after dilution. So if you are using a vial and you have diluted the vial, remember that a diluted vial can only be kept for 7 hours. And the infusion is supposed to happen over 1 hour. So 7 hours plus 1 hour for infusion. So maximum time after dilution is 8 hours. So when you dilute a vial, the vial has to be administered within 8 hours. If it's not, then you have to discard the vial. Keep the vial for around 15 to 30 minutes at room temperature so that it gets normalized and you can inject it properly. If you're using pre-filled syringes or pre-filled pens, do not remove the cap or cover. That has to be removed only just before injecting. Again, inspect for particulate matter or discoloration. The biological does not have any preservative, so you have to discard any unused portion. So when the vial or when the syringes are opened, you have to use it fully, and any unused part has to be discarded. And then inject the full amount. Okay. Now this is an image, and Ustekinumab biological is marketed as through a trade name of Stellara. So this is the Stellara vial. So concentration is 130 milligram per 26 ml, and That makes it around that sorry that makes it 5 milligram per ml. This is a syringe in which it is pre-filled either with 45 or 90, and I can see here it is written 90. So 90 milligram pre-filled syringe, and in which you just have to push the plunger, and this is 45 milligram subcutaneous use of pre-filled syringe. So you can see 90 milligram per 1 ml, 45 milligram per 0.5 ml. So this is an image that I have included. These are the injection sites: the anterior portion of both thighs, posterior aspect of the arm, just below the umbilicus where you have some fat collection. So that can be used as injection site, or bilateral buttocks. Remember to rotate the site up for every injection. So you can give first injection, let's say you can give first injection here, then second here, third, fourth, then fifth, sixth, then come back here and give here. So keep on changing these sites for injection, and make sure whenever you give any biological subcutaneously, you have to mention where the site of injection, so that it is not repeated subsequently. And do not inject if the injection site is red, inflamed, bruised, itchy, or any kind of deformity. Do not inject at that site. Inject at some other area. Okay. Now, how to give infusion? If you are using an IV vial, you have to dilute it with 250 ml of normal saline. Take a 250 ml normal saline bottle. Remove the required amount. So let's say you want to give 9 ml of ustekinumab, and 9 ml will be 45 milligram, okay, from the vial. So 9 ml 45 milligram. So from 250 ml you will remove 9 ml to make 241 ml. Then you will put 9 ml of ustekinumab and then inject it over IV infusion. So IV infusion has to be infused over 1 hour, and the whole infusion should be finished within 8 hours of dilution. Clear? So maximum time it can be stored after dilution is 7 hours, 1 hour for the infusion. So 8 hours after dilution has to be finished. Final volume has to be 250, because 250 minus 9 is equal to 41. Then you add 9 ml of ustekinumab to make it total 250. Clear? This is how to give IV infusion of ustekinumab. For subcutaneous technique, you just have to take the syringe out of the fridge, keep it for 15 to 30 minutes at room temperature, so it thaws away. Inspect for any particulate matter or any discoloration. Remove the rubber cap, inject it subcutaneously at 45 degrees, and then complete full. If you're using a syringe, you have to push the plunger to the maximum, and when the dose is fully delivered, needle guards will shoot out from the syringe and will cover the needle. The needle is going to go inside the syringe. Okay, and that is how you will know that the entire dose has been administered, and you can remove the injection. Clear? So here I am just showing you one pre-filled injection image of ustekinumab. This is how the pre-filled syringe looks. You have a plunger head, plunger, a needle guard activation clip. Now this is important. This is a viewing window. It's a glass window through which you can see the liquid which has ustekinumab. You can inspect the liquid to see if it's transparent. There are no particulate matter. There's no discoloration. You can even see the expiry date. This is the needle. This is needle cover, which is removed just prior to injection. Clear? Just remove the cap, inject it subcutaneously full dose till you hear a small click of needle guard activation, and then the work is done. Clear? So you just have to push it to its extreme and keep on pushing it till you feel the needle guards going inside and covering the needle. What we just want to say is just keep on pushing it fully extreme and wait to hear the click sound, which will tell you that yes, the whole dose has been administered. Injection has to be given at 45 degrees. You just pick up the tissue or the area which you want to inject it 45 degrees into the subcutaneous, inject it fully. Clear? Now we have discussed how to administer ustekinumab. Now we'll discuss few contraindications and adverse events associated with ustekinumab. Clear? Now Contraindications include hypersensitivity to drug or its components. Okay, any history of anaphylaxis through ustekinumab or any other components, angioedema, these all have to be taken care of. These are contraindication. One more contraindication that I would like to add is severe infection or sepsis. Remember that in cases of infective foci, you have to treat the infective foci first, then even consider any biologic. Okay. Essentially, there are no boxed warnings. Warnings can only be is attributed to infections which are same as other biologicals. Now, neurological side effect, there is a mention of reversible posterolateral syndrome. Previously, it was called as REMS, but the newer term is posterior reversible encephalopathy syndrome. Let me just write it here. Posterior reversible encephalopathy syndrome. PRESS. It is also known as reversible posterior leukoencephalopathy syndrome, RPLS. Same thing. So it has been found that these biologicals or proteinaceous structures can have some sort of neurological side effect which have been termed together to call as PRESS. The clinical features of the PRESS syndrome or the PRE syndrome includes headache, seizures, confusion, visual disturbances, and it has been found that after weeks to months of ustekinumab injection, for example, when you give injection of ustekinumab, the first injection of ustekinumab, there have been found a latency of few weeks to few months, and then the patient starts to develop this kind of neurological symptoms like headache, seizures, confusions, visual disturbances. And it has been said that when ustekinumab is stopped, these symptoms resolve on their own. We just have to make sure that we keep on asking our patients if there are any kind of headaches or any kind of confusion or visual issues that they may have been experiencing. Okay. Malignancies, like any other biological, theoretically it can increase the risk of malignancies. Loss of efficacy. Now remember that 3.2% of patients are going to create autoantibodies, and when body creates autoantibodies to foreign protein structures like ustekinumab, with subsequent exposure, the autoantibodies can destroy ustekinumab and there will be decrease in clinical efficacy. But 3.2 is a lower number. We just have to, this act as a good explanation of why biologicals fail on subsequent administration. But that risk is low for ustekinumab as compared to other biologicals like TNF alpha inhibitors in general and infliximab and infliximab in particular. Okay. The older pregnancy category is category B. The newer one is low risk. Okay. So this is somewhat similar to other biologicals. If I can remember correctly, Satorizumab Pagol was category C, older category, while all other biologicals were category B. So, and the newer rating says that these biologicals are low risk. Clear? Now remember that one of the important contraindications is infections. In any infective foci, do not give ustekinumab. If patients are more than 65 years of age, in old age, do not give ustekinumab. Any other comorbid conditions, better to not risk it. Patient taking concomitant immunosuppressant like corticosteroids or methotrexate. Now, if you're giving drugs in psoriasis, remember that they might be taking methotrexate also, Guo therapy, Soralens, narrowband, corticosteroid. Now, these are all excessive concomitant immunosuppressant, and it will increase the risk of infections and increase the risk of malignancy. So, you have to be very careful when patients are receiving multiple drugs. Now, no activation of latent tuberculosis have been reported with ustekinumab. What is the reason behind that? Remember that the body takes care of TB by forming granulomas. Now, what essentially is granuloma? Mycobacteria enters the body. Body is not able to kill mycobacteria. What it does is it picks up the mycobacteria and puts it in jail. Okay, it puts TB in prison and it holds a guard outside the prison. The prison is the macrophage. The guard are the epithelioid cell and lymphocytes which are surrounding the prison cell and not allowing TB to escape. One of the important chemical mediator which is responsible for this kind of granuloma formation is TNF alpha. So in previous videos, we have discussed how blockage of TNF alpha can have an increased risk of TB activation, because when you block TNF alpha, the guard is taken out of the equation and a mycobacteria is free to escape and then have an infection. But since Ustekinumab is not a TNF alpha inhibitor, it is interleukin 12/23 inhibitor, you will find that the activation risk of TB is not that much as compared to TNF alpha. Essentially, no activation has been reported. Now, you will say that these interleukins also lead to secretion of TNF alpha, and if interleukins are blocked, TNF alpha is blocked, and you will have the same issue. But that blockage is theoretically not that much. Plus, we have other sources of TNF alpha also. That is why the activation of latent tuberculosis is not that much a risk factor as compared to TNF alpha inhibitors. And I came across one paper in which INH, isoniazid prophylaxis, was given, and that has been found to be adequate for control of tuberculosis when a foci of latent TB was found. But remember that even if the activation risk is not much, you have to screen your patients for tuberculosis before giving Ustekinumab, because we live in a country where TB is endemic, very prevalent, and patient might have a focus of tuberculosis, which they found for the first time when you're evaluating them for a biological. So it's always a good idea and safe idea to give isoniazid prophylaxis and then give any biological. Clear? Let's go further. Now, the product insert of Ustekinumab mentioned that there is an increased chance of non-melanoma cancers, namely SCCs. Okay? But the case reports of SCCs are decreasing, and it's all theoretical risk factor, plus it has been found in risk factors when Ustekinumab was given for non-dermatological conditions like rheumatoid arthritis, ulcerative colitis, Crohn's disease, etc., where the doses are usually high. In skin patients, the role of SCCs have not been found that much, number one. Number two, if there is concomitant immunosuppressives like methotrexate, corticosteroids, or PUVA, they can itself lead to increased chances of malignancy, that also theoretically. So if multiple factors are acting in one patient, and each of them can theoretically increase the chance of malignancies, it's better to be careful. And remember, if your patient has any risk factors for developing malignancies, then not to give biologicals, and keep on screening your patients for development of any SCCs or any other malignancy. Clear? Regarding adverse effects, headache and nasopharyngitis were found to be the most common adverse event after Ustekinumab. Other infections like URTI or fatigue, pruritus, back pain, injection site reactions, arthralgias have also been reported. Okay. Serious side effects like diverticulitis, cellulitis, osteomyelitis, pneumonia, urinary infection, and cholecystitis have also been reported in individual case reports. However, the appearance of these side effects is not related to duration. These are not duration related, and these are also not dose related. Okay, so whatever the dose, whatever the duration, it can appear at any given point of time. Another concept that you will come across while discussing about side effects of Ustekinumab is MACE. 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 MACE is major adverse cardiovascular events. In other words, cardiac side effects. Okay. So MACE has been found to be rare with Ustekinumab. Okay. Furthermore, the presence of MACE is seen only as of now majorly with non-dermatological uses. In skin patients, the MACE has been found to be extremely rare. However, if your patient has any prerequisite condition which may impact its heart, it's better to screen for any cardiovascular issues, do an ECG, do stress TMT, do Holter monitoring, and also monitor for some also monitor or keep under follow up if your patient has any risk factors. Now remember that we are talking about psoriasis patient, and psoriasis itself is a risk factor for metabolic syndrome and cardiac disease. So remember that these indications are themselves a risk factor for cardiac issues, and in that case, ustekinumab will help them when psoriasis is decreased. Okay, but theoretically, ustekinumab can also increase chances of cardiovascular effect, though that has been found to be very rare in patients. Okay, so as I said, heart issues, demyelinating disease, which we found was more important side effect while using TNF alpha inhibitors, was found to be rare. Malignancies, injection site reaction, all have to be found as rare. No cases of TB activation or demyelinating disorder, the progressive myeloleukoencephalopathy or anaphylaxis have been reported with ustekinumab. However, there have been individual case reports for paradoxical pustular psoriasis activation. And most of the cases of paradoxical pustular psoriasis activation is seen with isolated interleukin 23 inhibitors, which includes your tildrakizumab, risankizumab, okay, guselkumab. So because of these isolated IL-23 inhibitors, you can have paradoxical pustular psoriasis. Just to keep in mind that is one paradoxical reaction that you can see with biologicals. For pediatric patients, they have to be brought up to date with all immunization as per schedule. Patient on ustekinumab can receive concurrent vaccination, but no live vaccinations. Also, if you vaccinate the patient with non-live vaccination, the chances of seroconversion is also decreased. They are not that much increased. The product insert mentions that no BCG to be given for 1 year prior and 1 year after treatment. So if you treat the patient for this duration, 1 year after completion of the treatment and 1 year before completion of treatment, BCG is not supposed to be given. And that is the product insert. It has not explained why, but I suspect it's because the inhibition of various cytokines will lead to activation of live vaccines in activation of the BCG organism, the bovis bacillus Chalmette-Guerin organism, and can lead to site tuberculosis or localized tuberculosis. Additionally, few case reports mention not to give rotavirus vaccine, and rotavirus vaccine is one of the most commonly given vaccine in India. So just keep an eye out if you're treating pediatric patient with ustekinumab. Now, drug interactions you can combine with methotrexate. It can prevent to some extent development of autoantibodies. Otherwise, no beneficial effect in psoriasis have been found. Other immunosuppressive like azathioprine or cyclosporin, they have not found to have good beneficial effect when combined with biologicals. So it's better not to combine and increase the chances of adverse events. No benefit has been found with TNF alpha inhibitors, anakinra and abatacept, same thing. Now cytochrome 450 substrate. Now what happens is that when interleukins like TNF alpha, interleukins like interleukin 6, when these interleukins increase, the formation of cytochrome P450 is decreased. So let's get this clear. When inflammatory cytokines increase, they will decrease the formation of cytochrome P450. Clear? So when we inhibit these interleukins or these chemokine cytokines by using ustekinumab, the cytochrome 450 will increase or become normal again. So all the drugs which require cytochrome P450 will get to be which require cytochrome P450 to activate themselves. They will get more activated and you will have more side effects of those drugs. So just to keep in mind, using ustekinumab can increase cytochrome P450 activity. So the drugs which get activated by cytochrome P450 will get increased. The drugs which are metabolized by cytochrome P450 will get decreased. Clear? So just a thought to keep in mind. In pregnancy, there is not much data about using ustekinumab. However, the newer categories say that it is low risk. The older category is B. No effects have been found on fertility in mouse and monkey studies. Of course, no human studies have been done. The product insert mentioned that contraception have to be practiced during 15 weeks after stopping. That means if you give ustekinumab for this duration, ustekinumab, 15 weeks after stopping, you have to continue contraception. Lactation, there is no data, but it's better to avoid because ustekinumab is a fully human Ig1, and we know that Ig1 gets not leaks through the placenta to the fetus, to the baby. So theoretically, it can easily pass through the placenta into baby circulation and can have immunosuppressive or immunomodulatory effects. Also, IgG1 has been found in breast milk, so in lactation, it can go to the baby and have its immunosuppressive effects. So, in theory, the effects of ustekinumab to the baby is mentioned, not mentioned, is theorized, but in real life studies or case reports, we have not found much side effects, and it's better if you can avoid and use maybe some other drugs till the lactation period is over or till the pregnancy period is over. It's better to go for other drugs, but it's if you think that ustekinumab or any other biological are going to benefit significantly, it's better to use it under practicing caution also, of course. Now, other interleukin 12-23 inhibitors, I'll mention one which is Guiacinumab. Guiacinumab was initial first interleukin 12-23 inhibitor, and the withdrawal of application was done in 2011 because there was lot of adverse events. So, because of lot of adverse effects, the application to approve Guiacinumab was taken back. Apilimod mesylate is another 2023 inhibitor which is under evaluation for rheumatoid arthritis and psoriasis. The important part is that it's an oral interleukin 12 and 23 inhibitor. So it's a good quiz question that apilimod mesylate. Apilimod mesylate is an oral IL-12/23 inhibitor and which is under evaluation in rheumatoid arthritis and psoriasis. But as of now, ustekinumab is the only interleukin 12/23 combined inhibitor. Clear? Now with that, we end our discussion on the first interleukin inhibitor in psoriasis, which is interleukin 12/23 inhibitor, ustekinumab. I hope I made myself clear how ustekinumab acts, what is the difference or slight differences between other biologicals and ustekinumab. Remember that TNF alpha inhibitors have more chances of TB reactivation as compared to ustekinumab. How does interleukin 12/23 act in psoriasis? So we have covered the salient features in this video lecture. If you want, just go back and see the video on psoriasis pathogenesis. It will make your life easier to understand different types of biologicals in psoriasis. And with that, I will meet you again next week with another biological. And this time we'll be discussing secukinumab, which is interleukin 17 blocker. Okay. So with that, thank you very much. Thank you for listening. And if you have any doubts, any suggestions, any queries, anything you want to communicate to me, you can either email me or it's better to write in the comment section. I reply to each and every comment that comes. Go back and see each individual video on biologicals, and with every time you see this video, you'll find it very easy to differentiate between the alag biologicals and see what is best suited for your patient. So with that, we'll finish this presentation. Practice sun avoidance and sun protection. Use an umbrella. Use sunscreen. The summer is not good. Tada, adios, and bye bye.